All right, everyone, it's 10:40, so I am going to bring us back for our next session. Thank you so much for coming right back after a brief break. Hope you had a chance to stretch. Again, I'm Kate Myers with the California Healthcare Foundation, and I'm so pleased to introduce our next presentation and breakout discussions, where we will focus on a topic we know has been really top of mind for a lot of you during the last year because of COVID-19, and that's the topic of virtual care. We all know that in the past year, the usual approaches to how healthcare is delivered were completely upended by COVID, and many of your organizations began doing more virtual care than you had in the past, as we just heard in the survey results in the last session. And it now feels like we're at what seems like a transition phase in California. We see vaccinations rising, COVID cases and hospitalizations and deaths dropping, and we hope those trends will all continue. And we're beginning to contemplate a future that looks different from the past year plus. And so we wanted to spend some time thinking about where does that leave virtual care in palliative care. So we've invited some guests from the Center for Care Innovations, or CCI, which is based in Oakland, to help us all think through what we've learned about virtual care over the past year, and to provide a framework for Medi-Cal plans and palliative care providers around the state to proactively consider your organization's approach to virtual care in the future, once those decisions aren't being driven by COVID and the emergency. And we're hoping that this session today will jumpstart some thinking and help you start or continue conversations within your organization and with your plan or provider partners about virtual care. Our guest presenters from CCI have thought deeply about virtual care and are working with safety net provider organizations around the state and around the country on telehealth initiatives, as well as other efforts to improve the health and healthcare of historically underinvested communities. So I'm pleased to introduce our guest speakers. Vinu Aulik is the Senior Innovation Fellow at CCI. She served as the organization's president from 2012 to 2020, and she continues to guide the strategic direction for CCI and advise the work on innovation and technology there. And Sophie Bergfest is the president of CCI. Prior to joining CCI in 2020, Sophie co-founded Access Health International, a think tank and implementation partner working on health system transformation with governments and the private sector across countries in Asia. We're also going to hear during this session from Dr. Ann Kinderman, who you just heard from in the last session, who, as you know, is the director of the Supportive and Palliative Care Service at Zuckerberg San Francisco General Hospital. And she'll be talking about some of the specific implications around virtual care in palliative care. So with that, I'm so pleased to hand it over to Vinu.
Great. Thank you, Kate. It was really fascinating this morning to be able to listen, to hear how palliative care has been evolving and setting the context for our talk today. So before I get started, I would just welcome, as you are listening, if you have any questions, to just chat those in and we'll try and answer them. Sophie and I are tag teaming from our team, so I'm going to get us started and talk a little bit about the context for virtual care, and then pass it over to Ann to hear a little more about what it means in the palliative care environment, and then to Sophie to talk about the framework. So for those of you who may not know us, CCI has been around for 20 years. We are a little bit different than most of the folks on the call, because we've been doing a lot to spark, seed, and spread innovations that strengthen the health and well-being of historically underinvested communities. And the majority of our work has been primarily in federally qualified health centers, public hospitals, a lot of behavioral health. We've worked with Medi-Cal plans. And a lot of the work that we do is really around supporting cohort-based learning and transformation around innovative practices. So we've done everything from setting up MAT programs to building resilience around sort of the ACEs screening initiatives. And then over the last 10, 15 years, we've been doing a lot of work around virtual care, which is a big part of our work around innovation and technology. And so we're going to talk a lot about that over the next half hour or so. So on the next slide, so what I wanted to do is set a little bit of context for how virtual care has shifted. Even prior to my time at CCI, I actually worked at the California Healthcare Foundation as well, and also did quite a bit of work around telehealth at the time. We didn't call it virtual care back then. Honestly, for the last 15 years working on telehealth, it's been a little bit like banging my head against the wall to get telehealth to get any sort of traction. It was very much, the work that we were doing was very focused in specialty care, looking at how it could be used to improve access to things like dermatology and ophthalmology and some behavioral health. And there was very, very low adoption in primary care. And much of that was driven by the fact that reimbursement was a significant barrier. There was regulatory issues that were significant barriers. And although there was thought that it was a great way to deliver care, the incentives were not aligned to do so. And then the pandemic hit and everything changed, as you all know. So there was a very, very fast pivot to virtual care. But a lot of what we've been seeing is, especially in the context of primary care, it wasn't necessarily rethinking what care should be. It was very much around how do we take the workflows that worked in-person and virtualize them, so to speak. And so, there's been a lot of work that it's amazing how quickly the work that we've been doing for so long just took root. We also, I think, for many years had heard that, patients, especially underserved patients, underserved communities, don't want virtual care, and providers didn't like delivering care in that way. And I think a lot of those preconceived notions were changed. I think there's been great interest. People see it as an important part of how care can be delivered. It's really changed access points in a very significant way. We're learning more about what it really means in terms of quality, especially. And now we're at a point where we're coming out of the pandemic, and really starting to think about what should be that ideal model and what should be done by phone, what should be done by video, when do you really need to do in person? And I think that's a lot of the context for our discussion today is how do we start thinking in a sustainable way that works best for patients and their preferences and that leads to high quality care, and what should that look like? So that's what we'll be talking about today. However, for the next slide, what I wanted to do is set a little bit of context. CCI has been leading 2 big virtual care programs over the last year, where this one that I'm going to talk about because we have the best data from is in partnership with the California Healthcare Foundation. And we're working with 23 organizations in California, really trying to, when the pandemic hit, was how do we really test and learn as quickly as we can? How do we get over some of the biggest challenges, see what it really takes to adopt virtual care, build a learning community around it? Because as we know, there weren't a lot of best practices when we started. We were all figuring this out together. And so looked at this program as a way to really figure out what's that infrastructure that's needed. How do we learn from each other? How do we share scripts and ways of doing things? And I think it's really was interesting because this is all in the context of primary care, but even seeing the data that you all shared this morning about how remote care, virtual care, video visits have played in palliative care into the future, it's clear there's a lot of parallels. So the next slide, just to give you a sense of the organizations that have been participating in this initiative. Some of them may be represented on the call today, but just to give you a sense that we're really talking about a range of federally qualified health centers, public hospitals, all across the state, rural, urban, small, large, and it's been very interesting, the sharing and learning that's been happening. So we wanted to share some data because I think this is fascinating to see. So as you can see, this data we started collecting, we had the organizations look back. So we started in December 2019, and as you can see by the blue, almost everything was done in the clinic back then. And then clearly in April, everything shifted. And the majority of the shift was phone visits. So you can see the orange part of it is the phone visits that really took over from virtual, from the in-clinic. And then the sliver of red are the video visits that have been pretty stable over time now at about 6% on average of the primary care encounters. I think the other thing that we didn't want to overwhelm you with data slides, but we've also collected this on the behavioral health side, which is very, oh, go back please, it was very similar, but it showed a slight difference in that red portion being a little bit higher on average, about 14%. And now on the next slide. Well, we also wanted to show you, though, that there is a lot of variation. And this shows that, you know, the median is, as I mentioned, about 6% in primary care. But you can see that there's a big majority, you know, 25% of the clinics are not doing barely any video visits. And then we have some clinics who a third of their visits are video. So this is just looking at video alone. And again, similar patterns in behavioral health with all the lines shifting a little bit higher, where the median is closer to 9%, but similar patterns as well. So on the next slide, so what we've seen over the year, I guess, yes, it's been a year now, that almost a year that we've been running this program, that the biggest challenges we're still seeing as we think about that shift to virtual is making sure that leadership support is there. It's a very, and that it's there for a sustainable future. I think there was a number of organizations that weren't sure how long, you know, if this was going to be the way of the future, and without that leadership support, it was hard to make those changes. We also found that providers and staff buy-in was really critical. Especially on the video side, it wasn't just a plug and play like everyone wanted. There were new skills that needed to be developed, new capabilities, and sometimes new roles, people who are having to help support patients who may have digital barriers, new workflows that were developed. And that all took a lot of time, and people are continuing to share ideas there. We also saw, especially for certain populations, where digital literacy was a significant issue, and knowing that we needed to put in place some mechanisms to help patients who may have language barriers or may not have access to Wi-Fi, some really interesting things that people have been trying to get around some of the digital literacy issues. And then there's also been, you know, interesting capacity challenges and ability to expand video. I think people quickly started up the programs and have been realizing the importance of getting the right platforms and how to like really scale this. And then lastly, I think there's a lot of uncertainty, or I think starting to have a little more certainty, but still unclear what's going to happen with the reimbursement into the future, and especially around phone, and how do we deal with those challenges. On the flip side, there's been some really interesting things that have evolved, and I'm sure many of your organizations have been doing this. You know, just around the workflows areas, we've been seeing some really interesting best practices, emerging practices of using digital equity screens, which is a way that people at check-in are finding out what are the patient's capacities, what devices do they have, do they need extra help, and really putting that into the workflows, using scripts. So everyone on the care team is really reinforcing the importance of video and virtual and what's capable by using those types of visits. a lot around preparing the patients. We have many of the organizations that have created instructional videos in multiple languages. In this cohort, there's a lot of people also using remote patient monitoring devices. So home-based hypertension monitoring is probably the most common, and curious if that's happening in the palliative care environment as well. And then I think, interestingly, this concept of the new roles and how people are leveraging tech advocates, how they're using volunteers to do prep patients and support some of those needs, because it's taking more time than I think providers would like to be able to support patients. And then I think what's interesting, we've been hearing about how by using Zoom rooms and breakouts, you're able to, people are doing some interesting things and engaging different kinds of care team members. So the warm handoffs with behavioral health and bringing behavioral health in. Some people on our last call were talking about how they're doing flip visits, where nurses can lead the visit and providers can come in for a part of the visit. So in some ways, there's some new opportunities that are evolving as a result of what the technology allows. And then I think a lot around optimizing that technology and how to pair some of the platforms with patient portals and leverage texting, and trying to do it in a seamless manner, I think has been interesting to see how people are figuring that out. So before I pass it over to Anne, I just wanted to end with just some considerations, and this will weave into our conversation for our breakouts as well, is just thinking about where we need more evidence to understand, like, where are the real inequities right now as a result of virtual care, and how do we help support and make sure that those inequities don't increase? How do we make sure that we are having the right type of care and type of visit that matches patients' preferences and the clinical needs? How do we make sure that we sustain this over time and figure out where those access points can really improve care over the long run? And then thinking about, as I mentioned earlier, still there's much more work to be done to address some of those challenges in supporting patients and using technology, and thinking about what can we learn, especially for our hard to reach populations who may not have the technology that's needed. So with that, I wanted to pass it over to Dr. Kinderman, who you heard from this morning, and she's going to share some of the unique considerations around virtual palliative care.
Thanks, Vinu. It's really helpful framing, and kind of appreciate so much the work that you all have done at CCI and thinking about, I feel like in palliative care, we hear a lot about switching to video visits and other things, but that is a much bigger lift in a lot of situations, working with the Medi-Cal population that everyone on this call is focused on. So I wanted to talk specifically about, Vinu was mentioning information that they have in working with safety net systems around use of virtual care in primary care and behavioral health, noting that there's a slight increase in use and video visits in behavioral health compared to primary care. And palliative care, I have as a symbol of plus, as we all think about palliative care as an added layer of support. So how does that fit in and sort of the considerations about when to use different modalities? And I will be speaking mostly from my perspective as someone running a palliative care program and doing clinic visits during the last year. Next slide. So some of the specific things that are on my mind a lot, particularly in an environment where there's you have freedom now to choose which modality is most appropriate for different patients, whether that's in person, video, or phone. And some of the things that I think about this is, number one, in palliative care, we do a lot of work around serious illness conversations. And, sometimes my experience is that can be challenging if you have never met someone face to face and you have only telephone visits with them. getting the engagement and entering into those conversations and sustaining that over a longer conversation can feel more challenging. And, we know that there are different proportions that have been reported in the scientific literature around what proportion of communication is verbal versus nonverbal, but it's certainly over half that's nonverbal, and all of the cues and things that you miss when you don't have a visual on a patient or a family member. Another thing that I think about a lot is if I'm having predominantly phone visits and I don't visualize a patient over months, what is going on with them physically? In our patient population, we take care of a lot of cancer patients, and you don't necessarily know if they're losing weight, if they don't have that perception themselves, or you don't specifically ask about it. But boy, when someone walks into the office and you notice change in their weight or how fast they're walking, or sometimes I have a patient who is quite anxious in terms of twitching or shaking when I see him in clinic, and over the phone, of course, you totally miss that. Another thing, if I have lots of patients with COPD or heart failure or cancer and they're more short of breath, when do I need to actually listen to their lungs and do that? So considerations for in-person or visualizing them versus phone. Controlled substance prescribing is something that has been talked about a little bit, but not as much as I would imagine in this patient population. The DEA has actually stated that in order to prescribe controlled substances, you need to, before that, visualize them either in person or by video. That is their directive. Once you've met someone, either video or in person, then ongoing prescriptions are allowed. But this is a big issue for patients who have big barriers to coming in person or doing video. And I think even beyond the DEA, just thinking about safety measures and monitoring when you're only doing phone visits is something important to think about. In palliative care, more so than in primary care or behavioral health, we have interdisciplinary visits as part of our care. And in the Medi-Cal population, we may need to add on a professional interpreter. So how do you think about doing those visits by phone or by Zoom? Certainly there are technologies that make those possible, but interesting considerations around, do we have the devices if all the team members are doing that remotely? How do we communicate as a team and make those connections as a team? I personally end up doing those visits in a room with my chaplain, even though we're doing it by phone, so that we can have nonverbal communication between us during the visit. Next, I think about the risk to our patients who have serious illness, particularly during the pandemic, of coming in to be seen or to receiving people to come into their home. And then the burden of transportation if they're coming to our sites, like coming to my clinic in San Francisco. Public transportation has been massively cut during the pandemic. So getting to my clinic is a very big deal and a big ask. And then lastly, thinking about caregiver engagement, which is so important in our population, there are certainly great benefits to, if you're doing everything remotely, then it doesn't matter whether a family member is on the East Coast or even in another country. But by the same token, sometimes you have less control over when and how those people are engaged and how much your patient is engaged versus the caregivers. And it certainly has been a big issue for in-person visits, as caregivers were not allowed during our surges in our clinic visits. So we just put those things in as because I feel like on top of all of the considerations and the framework that Sophie will be talking about, there are really important clinical things to be thinking about in palliative care and in our context.
Thank you so much for all those nuances related to palliative care and virtual care. So we put together a framework with considerations and decision points for virtual care. And the idea is that they're guiding questions that we hope that you can help you when you think about virtual care for the future. And we've divided it into 3 categories, where the first one is organizational considerations, starting with oversight of care experiences, quality, and cost for virtual care. So how are patient preferences understood and taken into consideration when planning for virtual care? And how is quality of virtual care reviewed at an organizational level? And policy changes. What policy changes should we be aware of? Looking back at the survey and the hesitation among plans, how much is that a reflection of the uncertainty of what may come as federal or state level policy changes? Right now, I would say that the California's Assembly Bill 32 is important to look at because it covers the future of Medi-Cal reimbursements for virtual care. And this bill is in hearing with the Committee on Health today. But please stay with us. Don't go and check on that. You can do that later. And in the framework, we have links to the policies that we think are relevant to keep an eye on. Current virtual care infrastructure investment needs. As Vino showed, there was a very quick flip in March 2020, March, April, to virtual care. But as we're looking forward, what is the appropriate infrastructure to accommodate high quality virtual care? And we have some checklists and framework in the framework that can help you assess your infrastructure needs. And on reimbursements, especially for the managed care plans, what information and evidence can inform your reimbursement policies if you're looking at optimal care, considering patient preferences, quality of care, cost efficiency, and so forth? And for providers, what are the revenue implications that you should consider when you're exploring changes in the modalities and the mix of care? And finally, risk management. How are you managing cybersecurity, patient privacy, and patient safety with virtual care today? And what could be what is more that you may want to do in that area? And once again, the framework has some resources for how you can look at that. The next category is operationalizing virtual care delivery. And there we have impact of virtual care on the care teams. So with a very quick change, about a year ago, team members' roles changed. But as we're looking forward, are some of those roles going to sustain? Would you like some team roles to evolve over time? And protocols. What is the preferred modality in terms of video, phone, and in-person, considering, once again, patient preferences, quality, cost, and efficiency? And how can you guide the providers and how to evolve these protocols over time as the evidence is also evolving? And what training and support do you provide to the care teams to deliver high quality virtual care? And team burnout and well-being. Zoom fatigue is something more and more people are talking about. And how well do you understand the current state of staff well-being and how that is affected by the multiple modalities of care? And how can you support staff well-being? What are resources to help you with that? Operational impact of different workflow by visit type. How well are the current workflows in virtual care understood, and how can these workflows evolve over time? We have in the framework a couple of resources, but in the coming months, we will have much more around the workflows. The Connected Care Accelerator members are sharing more than 100 artifacts, and the majority of those are around workflows, and we'll make that available to everyone going forward. The third and last category is addressing patient preferences and needs. So how do we measure patient satisfaction and understand patient preferences for the different types of visits? And how do we understand patients' digital literacy? Many organizations do a very simple screening to guide the proposed modalities of care visit, and we have some resources for that. And how can you support patient with technologies? Some rely on healthcare providers to guide, and as Vino mentioned, there's some that have been very successful using volunteers to provide that technical support. And how can we ensure that the support is available in different languages and a language level that the patients are comfortable with, both in terms of video and phone and in person? How can we use patient satisfaction data to improve the services over time? So these are guiding areas, and the framework is nothing fancy. It's a PDF document, and for you to get familiarized with it, we are going to have a quick resource scavenger hunt. So I have a question for you, which is, if you want to understand the digital access and digital literacy among your patients, what resources can guide you? And the idea is that you go into the resource, this framework, and you try to find the resource we have in mind. You copy the web link and put it in the chat, and whoever finds it first will get a virtual cookie and a virtual hug before we head out into the breakout rooms. But I'm putting this resource into the chat. And if you're unable to access SharePoint, I'm also putting it as a document, PDF document. Should be getting it here, 1 second. So off you go, and whoever comes first will get the virtual cookie. No, the right for the scavenger hunt. And if you have questions on the exercise, just put that in the chat as well. That's good to know that you can't open it. And you try to use the file. Oh, okay, we have a winner, Mary Joanne Ford. The winner, Mary Joanne, congratulations, Mary Joanna Ford. So that is the resource. I hope that, oh good, you're still downloading. It's not a large file, but I hope that you will be able to get it. This is also a way for you to just have this as a resource, and we are going to have more on the website going forward. So with that, we are going to get ready for the breakout discussion. We are a little bit behind time, but not so much. It will be about 30 minutes, and there are 3 questions. What are the most pressing questions that you need to answer for your organization to determine the extent of which virtual care will be used and for whom and how? And that, with that in mind, what is the additional information that you need to address the questions? And finally, thinking about what you have heard here today regarding virtual visits, what stood out to you or struck you as particularly interesting? So with that, we will bring you to breakout groups. We'll be back here at 11:40 and for a quick report out. So enjoy the breakout and see you back here.
So I think we wanted to go around and hear from each of the teams and hear what stood out for you all. I think we have about 10 minutes. So I will, yeah. Sophie, you want to start? I'll get at all the other names.
Yes, I can start. So in our group, it was interesting to hear the majority are really depending on inpatient care, vast majority, and the virtual care has been phone and as additional services, but the vast majority has been in-person care. And then there was a mix in terms of what will be the future role of virtual care. Among the organizations that are looking to virtual care as being, or virtual care being as a blended model of care being the future, the main challenges were around infrastructure on patient side. What does that look like? How can we provide the infrastructure, but also the support to what we had in the toolkit? How do you provide technical support to patient, but to providers to really make them feel comfortable? And what is the platform to use? The organizations in the room had not committed to a platform and not advanced workflows and so forth, but being very interested in looking at how virtual care can play a more significant role going forward. And one of the things that stood out as a high priority was to address transportation. If you can avoid transportation for palliative care, that was an opportunity that they saw. that was some of the highlights.
Great, thank you. Judy, did you want to share?
Sure. Yeah, we had a really good conversation, and there was a lot of kind of similar thinking between the payers and the providers in our group, and they felt that telehealth does work well in certain ways. It seems to work well maybe for certain disciplines such as behavioral health. It has worked well with goals of care conversations, including having remote family members. And that telehealth is better. There's some people getting care through telehealth that they wouldn't come in at all and be seen. But they really thought that first visit and developing that relationship, seeing that person in the home environment, and especially in the beginning when it's an interdisciplinary appointment, sometimes that's kind of overwhelming by telehealth. They felt that those are best if they could be done in person, and that clinical issues, the physicians in the group just definitely felt like there's a lot they pick up on about pain and symptom management and clinical issues that you're not going to get it through a telehealth visit. And so they really long for that in-person visit. All of them were feeling like, we're kind of just dealing with the way the situation is now, and we're just beginning to think like maybe what will things look like when we come out of COVID, and are in the process or wanting to make sure that they talk with their partners before they develop any final guidance. And some of them already have, like Melina said, that in their contracts, they ask that everybody has an in-person, face-to-face visit once a month. And so, it provides a lot of flexibility already, but they would like to get back to that. Blue Shield also mentioned that if telehealth is going to be such a big component of this, of palliative care, that if somebody's receiving palliative care through a clinic, they would probably extend the amount of time the person's receiving care through the clinic rather than move them to home-based, which is then going to be telehealth-based. So if it's going to be telehealth-based, keep the continuity of care with their current providers and move them to home-based when they really are going to get that in-person visit in their home.
Mm-hmm.
So those were some of the highlights.
Great, thank you. So given we have limited time, so the next folks, just if there's anything new that hasn't come up yet, we'll just add to that. So Monique?
Unmute myself. Hi, everyone. I'm going to focus in our group. We talked a lot about individuals who are homeless or sort of transitionally housed. And that really sparked this debate about their access to receiving care virtually, and recognizing that for many of these individuals, the complexity, of course, of maybe not, of course, but maybe having some behavioral or other psychosocial challenges, some substance use challenges. So looking at along with their physical conditions. So a few things was really prevailing is some flexibility, making sure that there's no one size fits all, approaching people in shelters, trying to work in tandem with hospice organizations that can go out to shelters, but also really being attentive to the fact that this introduces and will continue to represent a community that may have some difficulty using this. Just one other thing, we talked a little bit about sort of the intersection of providers and plans and making sure that implementation of virtual visits, the care delivery system is consistent for both. And of course, using a number of modalities. So that was it, really a focus largely on the homeless community and being attentive.
Great, thank you. Chris.
Yes, thank you. Our group really kind of all over the place, but really good conversation. And what came up, it seemed to come up a couple of times was, people would need to understand what the rules are going to be moving forward post-COVID, the DEA rules, the reimbursement rules. And in terms of balancing best practices versus patient-centered care, there was a request for some guidance on a good ratio between in-person visits, telemedicine visits, video visits. Should you have one in-person visit for every 4 telephone visits, or that it would be helpful to have some guidance around that to be able to move forward with that?
Yep. Similar things we heard too. Anne?
Yeah, thanks. We had a number of plans in my small group, and some of the questions that were raised around trying to figure out about are video or phone visits as effective as home visits, really trying to look at outcomes both clinically and also from a fiscal standpoint. So really looking at that, and then looking at other things like member satisfaction with the care, given that things have transitioned to much more virtual than in the past. And how often are the palliative care providers engaging with the plan's members compared to before? So I thought there were some really interesting things that some of the plans are tracking around whether this is going to be a good modality to support going forward. And the other thing that was mentioned is around kind of different structures where the plans are assisting their members, either with grants, with technology, and thoughts around how do we most efficiently help get members who have low tech literacy onto these platforms and comfortable with the technology, and different thoughts about that, particularly calling out community health workers and their role.
Great, thanks. And Kate?
Hi, thank you. So just a few additional points, some common themes from what we've already heard. My group was actually all provider organizations, and all of them had done some degree of virtual visits before the pandemic, ranging from a lot to a very little, and just experimenting with it. But of course, all grew during the past year, and all seemed open to continuing a combined model going forward. For many or most, I'd say the critical decision point for them will be around payment, not surprisingly, and understanding what will be compensated and how, and whether there'll be differences between video and phone. So that seemed critical. And people talked not just about patient preferences and considering, or that they've needed to and wanted to consider what patients want in terms of how to receive care, but some also noted clear differences among some of their providers and staff around their preferences and comfort in how to deliver care. And some noted that their ability to kind of accelerate this work really depended on having a provider or nurse champion for it. So that seemed like a success factor. And there was some acknowledgement that though there's a lot of thinking about kind of which type of visit to do for which kind of patient when, that hasn't really been codified. People haven't had the time or bandwidth to sort of crystallize, what do we do for wound care? What do we do for medication reconciliation? But a sense that there could be some differences there.
Mm-hmm. Great. Kathleen.
Yeah, you guys have mentioned a lot of the themes that came up in our group. I won't repeat. A couple of things that just merit emphasizing is one, just really this balance of virtual versus in person in terms of quality, that really getting answers around that is going to be determinative in terms of what this looks like going forward. A second observation, or recommendation, was that providers may benefit from extra training about how to listen or assess better when you just have phone. And in particular for patients and also for caregivers, that there's nuances and things you can learn to recognize, perhaps that people haven't just been trained in how to do it. And the third observation is just that it's sort of a tie-in to the issue related to what's paid for, is what we spoke about before of the tension, the difficulty of delivering palliative care at all in a fee-for-service revenue model. It's just that much worse if you're trying to do it with virtual care. And so the problems that exist, period, are just made worse when you're trying to do this through telephone or video. And everything else you guys mentioned, one of our plans is totally open to virtual care going forward. Looking forward to having more flexibility. The other one was in the, I have no idea yet what we're going to do. So we had a representative sample track to our survey results.
Great, thank you. And I'll just add on my, a lot, obviously being the last one, most of what you all covered, we talked about. The one thing that I would add that I thought was really interesting, Mary Ford spoke about, was how they're engaging patients using texting as well, and using Tiger Connect as a way to text patients. And then even through there, they're able to initiate video and phone calls, and how it's been a really, really simple way to reach patients, because some of the other providers were struggling with the video component. And we spent time talking about how text may be a really important mechanism to keep track of people and check in frequently into the future, and even thinking about where chat and some of these other modes could play in. So that was the only thing that I would add, but really great, rich discussion, and wanted to turn it back over to Kate. So thank you all for participating.
Thank you so much, Vinu and Sophie. And I'm just going to quickly close us out for the day. But I did want to quickly add, I know some people in my breakout group weren't able to access the link on the framework document. So don't worry, we are going to both email that around, and eventually it'll wind up on the CHCF website. We did a little screen share of it so folks could see it in my breakout, but rest assured you'll see it. It has some great kind of thinking, contemplation questions, and a ton of resources to help you think through those questions. So Sophie just shared it again. If you try again, you can see if you can download it, but if not, we'll get it to you. So in our last 3 minutes, I just wanted to start by thanking everyone for participating and hanging in for a few hours on Zoom. I think for me, part of the real highlights for today was hearing the results of the surveys that you all took the time to complete, to understand that we are progressing as a state. We are seeing increases in referrals and increases in engagement of patients, and yet we still see struggles with both plans and providers noting the struggle of engaging referring providers, ensuring that enough people who are eligible for these services get them. I was really heartened to see the emphasis on quality, that so many of our provider organizations are either certified or planning to become certified. And I think that really speaks to the maturity and growing maturity of this field within California. I think one of the things that also stood out to me in the sort of growth of these programs over time is the really critical nature of the plans in helping to identify and engage people who are eligible for these services because of the information that they have on people and their utilization, and in some cases, the relationships that they have through case managers and other staff. So giving us lots of ideas of different kinds of best practices to explore in future educational sessions. And gosh, on the virtual care front, I mean, obviously this is top of mind. There's a lot of variation in how people are thinking about this work going forward. We hope that the framework document, when you get it and have time to digest it, will help you really think through and be intentional about what your organization does, given some of the things that are out of your control, like federal and state decisions on reimbursement, but for the things that are within your control, to be more deliberate about your organization's approach going forward. Quickly wanted to highlight a couple things about tomorrow's sessions. First of all, we hope you are already registered for those. You will have a different login than you had today because they are 2 different meetings. So Kita will be resending everyone's confirmations for tomorrow this afternoon. So you'll see that in your inbox. Tomorrow, we're really excited to be focusing on 2 major topics. The first is on some descriptions of different innovations that are happening around the state. We have 2 health plans and 2 provider organizations who are going to be presenting really practical and specific tools and information about ways they're approaching particular problems and challenges in this care. So that'll be the first part of the morning. And then the last part of the morning will be around different experiences in implementing palliative care services, where we have some information about how plans and providers are doing this and doing it differently in some cases. And we'll have a chance for some discussion in breakout groups around that. So again, be on the lookout for your login for tomorrow. We'll start right at 9. And before we close, Kita just put into the chat a link to a short evaluation. We will also send this by email if you don't happen to, if you have to rush off to another meeting right now. But the time is now. You can log in now while it's fresh and complete the survey. We would really appreciate that. And with that, I think I have covered everything I'm supposed to cover for the close, but just wanted to again thank our presenters, Anne and Kathleen and Vinu and Sophie. And really thank all of you for your participation today, and see you tomorrow. Thanks so much.